Hi, my name is Candace, a fourth year medical student from Boston University School of Medicine. I'm currently on my sexual assault trauma informed care elective. After meeting some patients throughout this rotation, I decided to learn more about drug facilitated sexual assault and share what I have learned through this presentation. The target audience for this presentation is healthcare providers who are interested in learning more about how to take care of patients who are also survivors of sexual assault, whether it is immediately after the assault or months to years later. Most of the resources and information presented here are based in Massachusetts, but the general idea should be applicable to providers from other states. It is worth mentioning that in this presentation, I'll be using the pronoun she, but the survivor can be of any gender.
So a quick outline. We'll go over some basic definitions. Nowadays, sexual assault and rape are used quite interchangeably. So are there any differences between them? And what is drug-facilitated sexual assault, or in short, DFSA? Then, through a short case, we'll explore the importance in having a basic understanding of the following topics, including common substances used in DFSA, the toxicology investigation process, preventative measures, and the legal process related to reporting the sexual assault. Lastly, we'll wrap up with introducing some useful resources at the hospital level, state level, and national level. So rape is more of a legal term, and its definition varies slightly among different states. However, the definition is more or less the forced and non-consensual sexual penetration of any body part, whereas sexual assault encompasses any unwanted sexual contact, such as unwanted touching, kissing, or forcing the victim to touch a perpetrator in sexual ways. That's why you can see why sexual assault includes rape. Drug-facilitated sexual assault, or in short, DFSA, is sexual assault that occurs when alcohol or drugs are used to compromise an individual's ability to consent to sexual activity. Alcohol and drugs mainly work by sedating the victim and inhibiting victim's ability to resist, along with inducing anterograde amnesia to prevent victims from remembering the assault and the assailant. The FSA can occur in two ways, with the perpetrator taking advantage of the victim's voluntary use of drugs or alcohol, or perpetrator forcing the victim to consume drugs without their knowledge. There are some differences in the characteristic of each survivor group that can affect their service-seeking behaviors and preventative measures, and we'll address these differences in later slides. So, why this topic? Imagine you're doing your shift in the ED, and you have a patient who came in because she was sexually assaulted yesterday. She consented to a SANE exam, or a sexual assault nurse examiner exam, and mentioned that she is pretty sure that the assailant drugged her. But when you told her that she can submit her urine sample for testing of drugs along with her SANE kit, she told you that she is a mother of two, and she is currently being evaluated by the Department of Children and Families, or in short, DCF, for child custody. She has recently relapsed on heroin and cocaine, and is worried that consenting to UTOX will reveal recent drug use and that the results will be relayed to the DCF. So now, she is asking you, should I submit my urine for testing? Now, this is a difficult question to answer, but it also reminds us that we do need a basic knowledge of DFSA in order to better advise our patients. Let's start with the common substances that people think of when they talk about date rape drugs. This includes GHB, Rohypnol, and ketamine. Just by looking at this from the big picture, these three drugs all incapacitate the victim and cause amnesia of the assault. Because of the sedating effect, if the victim was given too high of a dose or has ingested alcohol at the same time, it can lead to severe respiratory depression and be life-threatening. These drugs are also cleared from the blood and urine quite rapidly, which is why it is crucial to obtain the urine and serum sample as soon as possible. Next, we'll look at each drug individually. We'll start with GHB, or gamma-hydroxybutyric acid. You might be more familiar with its other name, sodium oxybate, which is used to treat narcolepsy. As you will see, GHB, similar to the two other drugs on this chart, has a quick onset of action and lasts a relatively short duration. The drug is sometimes colored blue to discourage it from being used without the user knowing. But if it's not colored, it's really very undetectable, being colorless and only have a very slight salty or bitter taste. Next up, Rohypnol, or flunitrazepam. This is a benzodiazepine that is 10 times as potent as diazepam. It's used in some countries to treat severe insomnia, but not here in the US. Same as GHB, Rohypnol was previously available as a white tablet that dissolved without color, taste, or smell. But now it's formulated with a light green outer layer with a blue core. This change is to help identify tampered drinks at clubs. But really, try to remember that when this drug is dissolved in darker colored liquids, the blue dye really might not be noticeable. Lastly, ketamine. Although here it says the effect of the drug lasts about 1 to 2 hours, the user's judgment, senses, and coordination really might be affected for up to 24 hours or longer. And although the victim will experience amnesia, flashbacks have been frequently reported several weeks later. But at that time, it can be too late to collect any evidence. But even though there are all these common so-called date rape drugs that we just went through, it is important to realize that the most frequent tool that perpetrators use is still alcohol, just because it's legal and so accessible. And here are some more drugs used in DFSA. So basically, as long as it's sedating and disinhibiting, it can be in the toolbox of the perpetrator. And how are we going to detect what has been used? That leads us to the section of toxicology investigation. So a patient first needs to decide that she even wants toxicology testing. In the consent for the testing, she needs to confirm that the blood and urine samples are obtained within 96 hours or 4 days of the ingestion. Because like we talked about earlier, these drugs are usually metabolized very quickly. If your patient chooses to report the assault to law enforcement, she needs to provide consent that the law enforcement will have access to her test even if at some point she decides not to move on with the criminal process. On the other hand, if she chooses not to report to the police, she can still undergo testing, and the results will be available to a confidential service in about 6 weeks after the testing. This service will not have any identifying information except for your patient's kit number, which you will use to retrieve the test results. So, assuming the patient consented to a comprehensive toxicology testing, the blood and urine samples will be sent to the Department of State Police Crime Lab for analysis. The lab uses enzyme immunoassay and mass spec for the detection of many legal and illegal substances, along with some over-the-counter medications. So with that being said, going back to the difficult question that our patient asked us in the beginning, should I submit my plea given that I relapsed lately and am currently involved in the DCF custody evaluation? So it really is a cost-benefit analysis, right? Because if she has already reported to the police, once she consented to the testing, government officials will have access to her testing results, and there is no guarantee that the results will only be used for the purposes of investigating the sexual assault. If there is a possibility of the results being released to the DCF, then it might be a risk that the patient is just not willing to take. Also, because the date rape drugs are metabolized so quickly, the benefits of the testing may actually be very limited. So I think it's really important to fully go through this decision process with your patient so that she can at least fully think it through before consenting to something that she did not want and cannot take back. But of course, it's ultimately the patient's choice whether to submit the sample for testing, and all we can do is provide enough information for her to make an informed decision. So here are some commonly talked about preventative measures. Never leave your drink unattended. Just don't accept drinks from others unless it's someone you really trust. Arrive as a group, leave as a group, and always look out for each other. But it is kind of easier said than done, right? Especially for a lot of our patients who might not have close friends that can help keep them safe, or who are struggling with substance use disorder and are buying drugs alone on the streets. So beside the measures mentioned above, is there anything else we can do to try to increase awareness of sexual assault and its preventative measures? So this is a research done studying the differences in characteristics of survivors who were intentionally drugged through predatory DFSA versus those who were made vulnerable to sexual assault through the voluntary consumption of substances. The researchers found that survivors of predatory DFSA were more likely to be drugged via recreational drugs or non-alcoholic drinks, suggesting that the current public health prevention strategies, which have generally focused on the spiking of alcoholic drinks, should also increase cautioning people on the various ways in which a person may be drugged. The victims of predatory DFSAs were also more likely to have voluntarily consumed street drugs in the 72 hours before exam, had prior mental health problems in the previous 6 months, for example, depression and anxiety, and are also more likely to present later to hospital. Interestingly, the victims of predatory DFSA are also less likely to be students, suggesting that we should increase educational campaigns focusing on drugging and sexual assault to non-student populations. And here is a quick summary of the 2 important implications on preventative measures and the changes that can be made. Next, I want to talk about a research that studied the service-seeking disparities in patients who experienced drug or alcohol-facilitated rape versus forcible rape, which does not involve any substance. This is not talking about preventative measures, but I think it also provides a good perspective on what we can do to increase survivors' care after the assault. The researchers found that DFSA survivors are less likely to seek care after the assault due to the lower likelihood of acknowledging what they experienced was rape. This is potentially due to the survivor's experience being different from the social stereotype of quote-unquote real rape. For example, a survivor can have the preconceived notion that rape usually involves strangers who likely use weapons to threaten physical violence and inflict pain during the rape. If she were raped by a familiar friend who took advantage of her with little force while she was overly sedated to resist, then she may be less likely to acknowledge that what she experienced was rape. Another factor in play is that DFSA survivors may have worse memory of the assault due to the drug effect, which could interfere with rape acknowledgement. As a whole, these 2 factors call for a need to increase awareness of DFSA as rape, so that these survivors are more likely to seek care after the assault. Lastly, I believe it is crucial to have a basic understanding of the legal processes involved if the survivor were to report this assault to the police and start a criminal process. Please note that this section should be used as a primer for this topic and used for educational purposes. For questions regarding situations faced by particular survivors, please refer your patient to the legal services offered in your state. A good resource in Massachusetts is Boston Area Rape Crisis Center. Patient can ask for confidential free services from the Legal Advocacy Program. Alright, so after that disclaimer, let's dive into it. So first, what is the difference between a civil lawsuit and a criminal prosecution? Civil lawsuit is held when there is concern regarding any harm or injury to the rights of individuals, whereas criminal prosecution is concerned with acts that law defines as offenses, so as a harm to the society. This is why rape fits into both categories, and so the survivor can choose either way to go or both. For civil lawsuit, it will be the survivor who is the plaintiff versus the perpetrator who is the defendant. The survivor will need to prove that there is greater than 50% chance that harm occurred, and she can do it with a lawyer or not. And if the survivor wins the suit, she will typically be given monetary compensation from the perpetrator. While in criminal prosecution, it's the DA's office representing the state who's bringing on the suit. So it will be Massachusetts versus defendant, for example. The survivor will serve as a witness to the state's case in this situation, and the state needs to prove that the harm occurred beyond a reasonable doubt. In a criminal prosecution, the punishment is usually fine or jail time. So it's important to remember that lawsuit is public record. So if someone wants to find out what happened, they most likely won't be able to do that. Civil lawsuit typically has a strict 3-year statute of limitation, and the survivor can bring the suit against different people, such as the perpetrator for causing her harm, or the owner of the place where the assault took place. And once again, in this case, the survivor is suing for monetary compensation in civil lawsuit, instead of the punishment, such as the incarceration of the perpetrator. Whereas for criminal prosecution, the survivor can't really bring on the suit. She has the right to report a sexual assault to the police, which may lead to criminal prosecution of the defendant. However, the state, through the DA's office, makes the decision on whether or not to prosecute the perpetrator as a defendant after charging them with a crime. Alright, so wait, how does the criminal prosecution work? Again, in a little bit more detail. So let's look at this flowchart. The process gets started when the survivor reported the assault to the police in the city or town that the assault occurred. But actually, let's even rewind it a little bit more to a few moments before the survivor decides to report. First, she should review whether there's any outstanding warrant for her arrest or if she is engaged in any unlawful activity. If the answer is yes, it doesn't mean that she shouldn't report to the police, but it would be better to contact legal advocacy for more advice on how to proceed before she reports to the police. The process of making the report may also get frustrating, especially if the survivor needs to recount the same horrible memory to multiple different officers when the case happens to get passed on. Try suggesting calling the police department in advance to request an appointment with a sexual assault detective so that the survivor doesn't have to speak with other officers. Also, the interview can be very detailed and emotionally difficult. The survivor can request a volunteer from BARC to accompany her to the police station. Although the volunteer cannot be there during the interview, he or she will be able to provide the survivor support afterwards. After the survivor is done making the police report, the police will start the investigation. This process can take weeks to months. The police will talk to other people who may have relevant information, and this can include the perpetrator. If the perpetrator becomes aware that the survivor is moving forward with the criminal process, he or she may hire a defense attorney or private investigator who may contact the survivor or those close to her. Remember that anything said to the defense attorney or private investigator can be used against the survivor. At some point, when the police complete a sufficient investigation, the DA's office will make a decision on whether to move forward with the case in court. There can be many different reasons for the prosecutor to drop the criminal charge, and it doesn't mean that they don't believe the survivor. One example is that if there is just not enough evidence. Prosecutors have the high burden of proving beyond a reasonable doubt. So even if there is some evidence linking the perpetrator to the crime, it may not be enough to convict him or her. And without available evidence, prosecutors may drop the criminal charges. Then let's say after months to even years, the case finally goes on trial. Like all the other components of the criminal process, the trial is just as, if not more, stressful and emotionally draining. The survivor will need to testify at trial. This means that both the district attorney and the defense's lawyer will ask her many questions about the very private details of her life. Also, trials are open to the public. Although the survivor's name is not supposed to be released to the public, people could still attend the trial and learn of her identity. This entire process can certainly re-trigger a lot of trauma for the survivor, and as providers, it is crucial for us to check in with our patients regularly to ensure that they have sufficient social and mental health support during this process. I realize that I don't sound very encouraging about going forward with the criminal prosecution process, but that is just my perspective after reading about this topic. And honestly, this is a long process, but the survivor can always choose to start the process first and end it if things get too overwhelming. Just let the detective and the DA's office know. Even though the DA can technically still move forward with the case against the survivor's will and require her participation in trial, most likely the case will be dropped. So finally, take-home points. Amongst all the substances used by perpetrators for sexual assault, alcohol is legal and the most easily accessible. So it's the most frequently used substance. In terms of predatory DFSA though, victims are actually more likely to be non-students and be drugged via recreational drugs or non alcoholic drinks. This is different from common beliefs regarding sexual assault and are areas that we should work to increase awareness on. Another area to work on is increasing awareness of drug facilitated sexual assault as rape. Through helping more survivors acknowledge the rape, it is more likely for them to seek service post trauma. Lastly, there are many resources for survivors if they were to pursue a criminal process, or just for support after the assault. So please refer them to at least one. So here I listed some resources at the hospital level, state level, and national level. At BMC, we have SANE nurses who are trained to examine patients for collection of sexual assault evidence. We also have Link Clinic that is operated through the Women's Center and offers medical follow-up, family planning, abortion services, linkages to trauma-informed mental health services, legal advocacy, and Center for Infectious Disease to start patients on HIV prophylaxis. Then we have BARC, who I mentioned multiple times throughout this presentation. BARC provides free and confidential services to both survivors and their families and friends. They have a 24/7 hotline where the survivor can call for support at any time. Immediately following the assault, there are advocates on call, again 24/7, who will meet the survivor at the area hospital and accompany her for hours throughout the sexual assault exam and ED stay. Not to mention their excellent legal advocacy and case management service. Another resource for legal service is Victims' Rights Law Center, the first nonprofit law center in the country solely dedicated to serving the critical legal needs of sexual assault victims. On national level, there is RAIN, who operates the National Sexual Assault Hotline in partnership with more than 1,000 local sexual assault service providers across the country. So please, with all these resources available and all the caring people in the field, please relay them to your patients so that they are not left feeling alone and helpless after the assault. And that wraps up my presentation. Thank you for listening.